Ashman phenomenon is an aberrant conduction which occurs in atrial fibrillation. You can see that no P waves have been shown in this case. Very fine fibrillary waves may be considered, but this is a diagram. This is not an actual electrocardiogram. And when there is a long cycle in atrial fibrillation, we know that the cycle lengths can vary significantly, at least 50% from maximum to minimum. And when there is a long cycle which is followed by a short cycle, aberrancy can occur. That's because the recovery of right bundle branch conduction is delayed compared to left bundle branch. We usually say that right bundle is a bit lazy, and that's why most of the aberrancies are right bundle branch type of aberrancies. This is a representation of lead V1. In V1, you can see that instead of the R deepest pattern, an RS R prime pattern has occurred due to aberrancy. The importance of this Ashman phenomenon is that this may be mistaken for a ventricular ectopic beat. In atrial fibrillation, when there is a ventricular ectopic beat, especially if the person is on digoxin, it is quite significant. Digoxin is used for rate control in atrial fibrillation. So, if there is a ventricular ectopy or frequent ventricular ectopy, then it's an indication to stop digoxin and possibly, if required, restarted in lower doses. But if it is Ashman phenomenon causing aberrancy, appearing like a ventricular ectopic beat, there is no need to stop digoxin. In fact, you are supposed to continue digoxin. You might think why digoxin is needed, because there are other rate controlling agents. But there may be some persons who need digoxin in whom the other rate controlling agents are not suitable. Even now, digoxin is being used, though the use and dosage has come down remarkably, so that chance of digoxin toxicity being noted is very rare. Still, if a person has been on digoxin for a long time and later develop renal failure or chronic kidney disease, there is a possibility that we may still see digoxin toxicity. After Ashman had described this phenomenon, later Fisch has described a few criteria for diagnosis of Ashman phenomenon. First is, of course, the long-short sequence. Long-short sequence terminating in wide QRS. Most often it is right bundle branch type of aberrancy. Occasionally left bundle branch type of aberrancy has also been described. Then occasionally, instead of long-short, short-long has also been described, but we will not discuss that. That is difficult to understand. In long-short sequence, the reason for aberrancy is that when the cycle is long, refractory period is lengthened. So, after a longer refractory period, when the short cycle comes, the bundle branch has not recovered fully. So, this long cycle is responsible for the aberrancy, that is prolongation of refractory period. Then the second criteria, right bundle branch block aberrancy has a normal initial vector. This is the normal initial vector, small r wave, and that is preserved. This will not be there if it is left bundle branch block aberrancy. We know that in V1, the initial vector is abnormal in left bundle branch block. If it is left bundle branch block, this initial vector will not be there. It will be a QS in V1. So, if it is RBB aberrancy, the initial QRS vector is preserved. That is because normal activation of the septum is from left to right. That is which produces this. The reason is that conduction down the bundle branch system is faster in the left bundle, so that septum gets activated from the left side to the right side. That is what is causing this. Correspondingly, in lateral leads, it will be a small Q wave. Then varying coupling intervals of the aberrant QRS. That is because this is the coupling interval. Usually, ventricular ectopy, which is of the reentrant variety, has a fixed coupling interval. That's because it takes a particular time for that circus phenomenon or re-entry to occur after the previous beat. So in ventricular ectopy, the coupling interval will be constant in usual ventricular ectopy. But there is also a form known as parasystole, where it is due to an ectopic focus and the focus is protected from other activations. In that case, there is varying coupling interval in parasystolic ventricular ectopy. That's a rare situation. We think of the common situation, which is re-entry. So the focus is not protected from the other activations. So there is always a fixed relation of a fixed coupling interval. But in AF, it is not like that. AF, it is the next impulse getting conducted from atria. In ventricular ectopy, the impulse is generated within the ventricle. So it has that conduction sequence and fixed coupling interval. In atrial fibrillation, we do not know when the next impulse gets conducted across the AV nodal system. So this coupling interval can vary in aberrant QRS of Ashman phenomenon. That is a third criteria by Fisch. Then fourth is also same reason. Fully compensatory pause is not seen in Ashman phenomenon because the underlying rhythm is atrial fibrillation. Only if the underlying rhythm is sinus rhythm, the full compensatory pause occurs in ventricular ectopy. That's because in ventricular ectopy, the ectopic beat does not get conducted back to the sinus node to reset it. So when an ectopic occurs, at that time, the sinus beat which occurs from above does not get conducted to the ventricle. And the next sinus beat gets conducted at the exact position. So the coupling interval is fixed and the interval preceding it is also fixed. So that causes a fully compensatory pause in sinus rhythm with ventricular ectopy. Here it is not seen like that. Then another aspect in that case is that in supraventricular ectopy, that fully compensatory pause is not seen. That is also similar reason. Here also the rhythm is atrial. There also the rhythm is atrial. So that's how Fisch criteria helps in the diagnosis of Ashman phenomenon. Sometimes another interesting phenomenon occurs in Ashman phenomenon. That is, this type of sequence may be seen. At one look, we'll think that it is a run of ventricular tachycardia, non-sustained ventricular tachycardia. But if you look closely, all of them have right bundle branch block aberrancy type of pattern, R prime pattern. And this is initiated by a long short sequence. So the first beat is initiated by an Ashman sequence. For the subsequent beats, there is no long short phenomenon. So that is not due to Ashman phenomenon. They are due to concealed transseptal conduction. That is, across the septum it is conducted to the opposite ventricle, producing aberrancy. So right bundle branch block aberrancy is maintained for a variable period. That is the cause of RBBB type of pattern.